Hello everyone on the webinar. My name is Richard Cohen and I have the privilege of being Chief of Surgery and Chair of the Institute of Digestive Diseases and Surgery at Cleveland Clinic, London. And I'm running this, hopefully not just this one, but a series of talks entitled Inside the Experts' Minds, where I'm going to interview some of the great masters of surgery and ask them how they got where they got. And I hope it's going to be a very interesting half an hour. And I'm delighted and privileged to have my old master, Professor Robin Phillips, Honorary Consultant Surgeon at St Mark's Hospital and Emeritus Professor of Colorectal Surgery at Imperial College, with me this evening for a fireside chat without the fire or the wine or the whiskey. So if I could just have my first slide, there's a couple of slides here. That Cleveland Clinic has been around for 100 years as of February the 25th, I think it was a few weeks ago. It was founded in 1921 by four physicians: George Washington Cryle, famous for Cryle forceps, mosquito forceps used in neck dissection; William Edgar Lower, who was a genitourinary surgeon, and two other physicians, Frank Emery Bunce and John Phillips, who decided that they worked so well together during World War I as a team that they would start a team-based practice in the United States. And the Cleveland Clinic has gone from strength to strength ever since. And if I could have my next slide, please. So I won't take you through all of these, but just to say that the values of the Cleveland Clinic in purple there are quality and safety, teamwork, empathy, inclusion, integrity, and innovation. And it is a true patient first comes first organization. So if we can now switch to the session with Robin and myself, you can take the slides out. Thank you. Let's see. So Robin, it's a great pleasure to get this chance to ask you all those questions that I wished I could have asked you when I worked for you as a senior registrar or RSO at St Mark's and as a consultant colleague all those years ago. So I know you had a very interesting upbringing. Why don't you start by telling us where you grew up and about your early years?
Right. Well, I was born in Barnstable in Devon, and my father was a district commissioner in the Sudan in the 1940s and 50s after the war, and my mother had actually trained as a doctor, and she ended up as being the first non-missionary woman surgeon in the Sudan. And we lived in very out of the way places, 70 miles trek on horseback from one place to the next. My mother flew home to have children when she had the children at home, and then we went back there. When Sudan had independence, my father became a diplomat, and he was an Arabist, so he spoke fluent Arabic. And it meant that I ended up going to boarding school at the age of 7, because some of the countries had no schools, and it wasn't possible to be educated other than going to boarding school. And there you are. That was my background.
And so, was there some event that made you decide you wanted to be a surgeon? I have a textbook from when I was 7 years old where I wrote, "When I grow up, I want to be a surgeon or a train driver or a fireman." Was there something in your life that that pushed you that way into medicine and surgery?
Probably. My mother's father was a surgeon in the West Country in Devon, and because my parents were overseas, I would spend 1 or 2 holidays a year with my grandparents, and I would see my parents 1 or 2 holidays a year. I never saw them in school time. They never came to prize givings or anything like that because they weren't in the country. And he was a surgeon in the West Country, and I was extremely fond of him. And of course, my mother had trained as a surgeon, so I had that in the background. My father, of course, was a linguist, so he spoke Arabic, Greek, and Urdu, and had been a soldier in the war.
And remind me which medical school you went to.
Well, I went to the Royal Free, which is where
Right.
my mother went to. I mean, I don't know. Nowadays, I would never have got into medical school.
No, me neither.
Firstly, I had terrible A levels. I had C, D, and E in A level.
Wow.
Secondly, when I went to the interview, I forgot to visit the gents beforehand, and I had a bursting bladder all the way through the interview and tripped over the carpet on my way in, and just was desperate to get out. So I was very, very lucky to get in. It was only really when I got to clinical medicine that suddenly it all started to come together, and I really started to enjoy all the aspects of medical training.
And in terms of surgery, what did you I know in my day there were this sort of surgical training numbers and things. How did you get into that side of the business?
Well, in our day, the real difficulty was to become what was called a senior registrar in those days. Whereas you could get, there was no proper career structure, and you found intermittent jobs, and so you would have a job for 6 months or a year, and you would do your SHO time, and then you would become a registrar. And once you had your fellowship, you were then a middle grade registrar, and you tended to do about 2 years middle grade registrar. I had my fellowship 4 years after I qualified, and I qualified at 22, so I had the fellowship at 26. And then it was looking for a research post, and it was extremely difficult to find, and it was very serendipitous. The first thing I tried to do was learn an immunoassay for prostacyclin, which I learned at the Hammersmith in my spare time. And then I would have gone down the lines of a vascular surgeon if I'd sort of done that. And then I was asked to deal with malignant melanoma. And then it was getting the money that was always difficult. Then metabolic water, and then eventually there was a thing called the Large Bowel Cancer Project, which had been set up by someone called Peter Fielding, who had gone to the United States, and it was fairly defunct, but there were 4,500 patients on mainframe computer, which you accessed using punch cards, and you had to do all the programming yourself. And deal with that, and no one wanted to touch that like a barge pole. But I had come to the end of real hope and employment, so I held my hand up and said, well, I'll do that. And then of course it all started to come right, and lots of interesting publications at the time came through, and that helped.
No, I mean that's still quoted widely. A lot of the output from that project that you took on. So is that what got you into? So you sort of fell into colorectal surgery, or it, I assume from that. Clinically, how did you get involved in colorectal surgery?
Well, in terms of in our day, a lot of people who went into colorectal surgery would have done vascular research or common bile duct research, or it wasn't necessarily connected that what you did your research in was where you ended up as a practicing surgeon. But towards the end of that time, and I was obviously towards the end of that time because I was looking at the people in front of me, it made sense to me that if I had all this knowledge from the Large Bowel Cancer Project, I might as well turn it to a good end and make a plan to become a colorectal surgeon. I mean, even today, it's all general, it's general surgery, and we didn't have an exit exam in colorectal surgery at all. It was just general surgery, and you sort of declared yourself of what you wanted to do. But for pretty much every hospital, except for St. Mark's, you were a general surgeon as well as a colon rectal surgeon.
And sort of how did you hear about St. Mark's, and tell us the story about how you came to become a consultant there?
Well, I was turned down 3 times for an RSO job. So I applied for RSO positions and failed. And I remember the 3rd time that I was turned down being asked by John Nichols in a interview. John Nichols, very famous surgeon, I think a lot of people will know. And at the interview, he said, and what do you think is the greatest advance that has happened recently in colorectal surgery? And he sat back looking smug. And so I sat there for a moment and I said metronidazole, because that had just come out and was making a huge difference to infection rates. Well, needless to say, I didn't get that job when I was interviewed on that occasion.
John Nichols obviously famous for his ileoanal pouch and taking on the Parkes pouch. I'm sure that's what he was speaking about.
Clearly what I knew he wanted me to say, but no, I ended up not doing it.
Did you ever quiz him in later years as to that disappointment and whether that contributed to your...
I don't know that he would have chosen to remember it. I certainly remembered it, but didn't think it was wise to bring it up.
And then the switch from RSO, I mean, I followed you years later, the switch from RSO to consultant. Did you apply for jobs elsewhere, or you only went for the post at St. Mark's?
Well, I think on the way through, there was a link made with Toronto in Canada, and I was the first exchange fellow who went out to Canada and spent a clinical, only 1 month, but a clinical month in Toronto, which for me was transformative to go there. It completely changed everything about every aspect of how I operated, because back then no one used electrocautery for surgery. It was all knife and scissors, and but in Toronto they were all electric surgeons. And so when I did come back to St. Mark's, the joke used to be that they would send me the electricity bill, because everyone else thought this was a bizarre way to operate. But answering your question, no, I applied for senior lecturer position in Leeds, and went for that, and McMahon was the incumbent who actually got the senior lecturer position. And then the post after that, the St. Mark's job came up, because we never knew when these jobs were going to come up or actually get appointed. It was retiring man's shoes that you were going for. So I was just lucky to get that post.
Did you take over from someone else when you took up St. Mark's, Robin? I don't remember that.
Yeah, officially Ian Todd was the person who had retired. He was president of the College of Surgeons, and then subsequently I worked as a consultant with Charles Mann, and then when Charles Mann retired, he wasn't replaced at the time, so I sort of took over both of those practices. But Ian Todd had been president of the College of Surgeons and not been working very hard clinically, and anyway had been absent for a year by the time I started.
So that must have been quite a fun time for you. Were you in one of the, because traditionally St. Mark's had joint positions. John Nichols, I know, was on at St. Thomas's, and I think James Thompson may have been on at Bart's as well. Was yours a just a St. Mark's post?
No, I was 7 sessions senior lecturer at Barts with Richard Wood, who was a vascular and transplant surgeon and department in a vascular department, doing the sort of colorectal surgery there, and 4 sessions at St Mark's. So I was doing that sort of joint bit, and in those 11 sessions, just to get us up to date, I did an all-day operating list at St Mark's and an all-day operating list at Barts. I did an outpatients at St Mark's and an outpatients at Barts. I did a colonoscopy list at St Mark's and a colonoscopy list at Barts. I did on-take in general surgery 1 in 3, and I had 4 full-time research fellows.
Wow, that's pretty full on. I think I don't think that sort of thing happens today. Can I ask you, Robin? So, through your training in your early years as a consultant, I know who I'd come up with, and you'd be one of them. Were there any sort of major influences in terms of your colleagues and the people around at the time?
Yeah, I think I mean the one in the background was Professor Hugh Dudley, but he's not the one I'm going to go on about. There were 2. A guy called Jack Bradley. Jack Bradley was a vascular surgeon who worked at Hillingdon Hospital, and I was there for a year with him as a surgical registrar. He subsequently married Avril Mansfield, who was the vascular surgeon at Mary's and vice president of the College of Surgeons. And what I remember about him was he was just an excellent craft technician. He really thought about the craft. And the other person who was a very big hero of mine was Zane Cohen. So Zane Cohen in Toronto, he was, he again sort of transformed the way I thought about surgery and the way surgery should be done. Because when you go back, at the end of my training, all through my training, the interest was not in the craft. It was in the decision making, so that an operation could never be better than the decision to do it. But what it meant was that a lot of the surgeons were not teaching fine technique, craft. It was very rough and ready. And of course, in the open surgical days, and I'm now meaning before electrocautery, because I was an open surgeon, it was the pelvis, the hand thrust into the pelvis and guddling. It was there are essentially 2 types of surgery. One is C surgery and the other is touch surgery. And with C surgery, what you do is it's like watching a slide presentation. You put up a slide, and that is the scene that you're going to operate in. And it's like it happens in laparoscopic surgery, but it's what happens in electric open surgery as well. You make it the slide, you watch how surfaces move over each other, and you learn where to cut. In touch surgery, it's more like a movie. It's not setting up, it's moving along all the time. And as it moves along, you're not so much seeing as you're feeling planes, feeling differences. And one of the things that happens is that in the most difficult operations, the really most difficult operations, you can't see anything, and you have to be able to do touch surgery. But there are going to be very few people who know how to do that in the next generation, and there is going to be quite a lot of difficulty in training surgeons in open surgery, because if you look at a standard hospital, then clearly the large majority of work is going to be done minimally invasively by expert craft surgeons. But the real nightmare operations will need to be done open. And the question is, how are we going to train the open surgeons? Because you're going to need to have, probably in any major institute, a couple that you can who can take on the really nasty open surgery. But it takes a very long time to learn how to do open surgery. So I think that's going to be a bit of a problem.
Because you know, watching a video of an operation done laparoscopically is very easy. So you go to YouTube and watch the procedure. Whereas I agree with you, being shown how when your hands are in the pelvis and or in a very difficult situation is not something that videos well. And I remember when we did live surgery, that videoing live surgery is actually very difficult, except perineal surgery, which is, but videoing abdominal and pelvic surgery open has always been quite difficult, hasn't it?
Yes, because again, the whole thing about video will go with C surgery, because firstly, of course, using electrocautery or other energy devices, you don't get the bleeding, and therefore you don't absorb the light, and therefore you can see clearly, and that's fine. But with touch surgery, what you're trying to do is break down adhesions with your fingers by pinching and finding the way, and you can't show those sorts of things to know where you can blindly cut with a massive pair of scissors, and how exactly to do that. Those things are very difficult to train.
And so, if you brought me onto the topic, so what are your views on minimally invasive surgery? And the other thing I was going to ask you about is things like TATME. Are you wary of these techniques, or do you think it's just another tool in the box?
I mean, I was there obviously through the development of minimally invasive surgery, and went off to the United States to learn how to do early colon laparoscopic surgery in pigs, and came back and did start doing some early on. So I did a few at St. Mark's at the very, very beginning when it was first coming out. But in those days, the equipment was very poor. The equipment was being invented, and quite honestly, the only reason for doing this surgery at that time was to change the length of the incision. It really made no other difference. And I think now, obviously, minimally invasive surgery is going to be the bread and butter surgery that is done. And the equipment is very much better. The video is very, very much better. The training is all in place. So I see that as being the majority. But as I mentioned earlier, very difficult to train people when the laparoscopic surgery has become too difficult and they actually have no skills in open surgery. So that is going to be an issue down the line. If you go to TATME or TATME, you know, I know that the colorectal disease only last in February was really talking about how there needs to be a pause, and the Norwegians had paused it, and that the Association of Coloproctology had paused it. But I think there is a bigger issue that goes on. The most skilled laparoscopic surgeons can actually do the operation without using TAPME. There's only a small number of cases where a good laparoscopic surgeon would struggle, or a good robotic surgeon would struggle. These are going to be big men, that it's really going to be the difficult thing. The difficulty is that there is quite a learning curve to be able to deal with TATME, and there's also a problem with keeping up your skill set for doing it. And what this means is that there will be people who have decided to take on TATME who will probably do it in a number of circumstances when it really doesn't need to be done in that way, and probably shouldn't. And what really needs to happen is that we should have 1 or 2 TATME surgeons in the UK, and they do that all the time in these difficult circumstances, and the cases are referred. But I think that is very wishful thinking that that sort of thing will happen. So I think it is this difficult thing about controlling the development, and nevertheless it probably has a niche if you could control the development.
Robin, just as we cut, I'm finding this is wonderful chatting to you. What do you think over the next 20 years? What would you predict as being the next great changes in the field of colorectal surgery? Any thoughts on that?
Well, this recent COVID epidemic, one of the things that really sort of excites me was the mRNA technology, the Pfizer and I think Moderna vaccine, because one of the things about vaccine development has been, I'm going down towards tailored cancer therapy.
Right, yeah.
One of the things about vaccine development has been the huge cost and the ability to get the authorities to allow you to change a vaccine and then not have to go through a large-scale trial. Now, with the mRNA, what you can do is you can just change some of the letters in the core bundle. It's like you've got a postal service and you're just changing the address slightly. Now,
if I could stop you, what do you think the technical advantage will be in the next 20 years? I completely agree that using all the wonderful abilities to alter RNA and DNA will be, but what about technical things? What's next?
Well, I was going to finish the point, because the point I was moving towards is that individualized chemotherapy and immunotherapy will be possible because it will be licensed based. They won't go through a licensing process just to change the address. So put that to one side. Well, the other two things that I can sort of think of, which are not really going to be so much technical, but what's going to happen over the next 20 years, and I don't think I would like to be there to see it, is that we are going to be increasingly British Airways pilots, that they're not your patients, they're the trust patients. You won't have met them before, someone else will have assigned them to a trust aeroplane, and you will get on the trust aeroplane and you will pilot it from A to B and get off and walk away, and someone else will pilot them back when they come home. And that sort of thing, I think, is going to happen. So individualized from the surgical point of view, from the practitioner's point of view, we are going to be very much more controlled, and we are going to be very much more like a commercial pilot. But asking you, what would you see coming over the horizon in terms of craft? Because you asked the question. So what would you see as coming over the horizon?
Well, I suspect that they'll continue to develop the minimally invasive techniques down to the notes type natural orifice surgery, or inserting a device into someone's abdomen that will crawl around and like a spider and fix whatever it is inside. I think that the combination of computing power and AI and will make minimally invasive surgery almost automated, I suspect, in the end. And I think AI will have a big part to play in that. I think it's going to be quite interesting. And as you say, we'll lose the skills. They'll have to wheel you and I out of old age homes to come and show them how to open an abdomen and do it the old-fashioned way.
What you'll be left with is trauma surgery, you know, because when someone gets smashed up, you know, then you're going to have to be able to deal with that, and dealing with when it all goes wrong.
Yeah, that's the interesting stuff.
You're back to the big open type surgery. So I think, in a sense, that swing that you've indicated, I sort of flagged up earlier, is we're going to have to start training open surgeons again to be able to do open surgery, because the vascular surgeons in my generation saw an awful lot of their surgery disappear. Because the catheters came in, because the stents came in, because the EVARs came in, all of this stuff, it sort of ended up disappearing. They had been doing great open surgery, and that went. I think the generation of highly minimalized surgeons could find that they become the equivalent of interventional radiologists, and that the actual surgery that you and I trained in will have to start to be trained again.
We've got a few minutes. We're running over slightly, which is fine. I've got two more questions for you, Robin. My first question is what do you view as your personal greatest contribution during your career to the colorectal world? Is that a difficult question?
I mean, I find that very difficult. All that I can say is that I showed an interest in inherited cancer and was involved with polyposis, not only in the UK but worldwide, and was interested in taking the development of that and rare genetic diseases forward, and very happy to have passed that on to Professor Sue Clark, who's doing a wonderful job with that. And then I learned from James Thompson about fistula surgery, and got very much into fistula surgery. When you arrived, I handed it all over to you, and it's only when you left that I had to climb back in to do fistula surgery again, and then handed on to Phil Tozer, who's now at St. Mark's. So I think those two areas of polyposis and fistula surgery are the areas that I've done the most in.
I mean, I would add that you're a wonderful mentor, and your particularness in technical surgery, as you alluded to before, has guided many of us, and you've trained many of us how to do open surgery in the way that is needed. So I think there are many more things that you've contributed. But I can see that handing down the St. Mark's Registry and your work on fistula were great contributions to the field. As a last parting question, just say that you were talking to a second-year registrar who wanted to pursue a career in colorectal surgery. What would you advise them to do to get them into a good position to be a consultant and make a difference in years to come?
I would probably say that all careers of the sort that you and I have had require a very large commitment, and the commitments not only from yourself but also from your nearest and dearest, and that is a very important thing to put in your mind's eye, because it becomes very easy. And now I sort of talk to myself, but it comes very easy that you come home at the end of a long day and you're feeling knackered and in a pretty bad mood, and you want to sit down with a gin, and the dog comes up to you and you kick the dog, and you're not feeling in the right frame of mind, and your partner may have been particularly when you've got young children, and I'm now talking from a male perspective, and from my generation, when my wife was at home at times looking after children, she wouldn't have been talking to any adult. And the main thing that I learned was that when I came home, don't go into that shell, but go and sit in the kitchen, was the place we would sit, and I would ask her about her day, and we'd talk about her day, and we would go through those things. It's really important, if you're going to take on a career, that you look to other things. Bear in mind that you didn't make a choice about your children just happened, but you chose your life partner, and your commitment is to your life partner, and you need to give that time. So if I was talking to anyone coming through, I would say, if you've got a life partner, you've got to nurture that, and that requires work and consideration. That is the more important thing than carrying gongs or whatever in terms of your surgical career.
That's great advice, Robin. And if I'm allowed, one last question that cropped up in the chat is, just say you were allowed to change one aspect of your career journey to retirement. Is there something that you do slightly differently or majorly differently? Maybe not. I'm not. I mean, you have an outstanding career.
Well, no, I think the real thing is that I have been too much of an individualist. I've not, in terms of the political world, I think that if you want to rise to being president of this or leader of that, then I think you should learn to avoid the bon mot, the easy, amusing comment that it isn't very helpful to do that. You need to be politically much more adept. But I never wanted to be in that position. I would have been absolutely awful in those sorts of positions. I felt that being at St. Mark's was a privilege. I felt leading St. Mark's as clinical director for quite a number of years was a great privilege, and being able to do the research, I didn't want to be anything else than that. But if one did want to be anything else than that, then you've really got to develop your political skills.
Robin, it's been an absolute pleasure to spend the time chatting to you, and I could go on for another. Maybe we'll go and have a drink one day, and we can carry on. Can I ask? I'll give you the last comment on the floor. Is there anything you'd like to say to me or the audience?
Well, well, firstly to you. You've always been a wonderful friend of St. Mark's. We always thought you were tremendous. I was delighted that you were appointed to be the leader for digestive and everything else at Cleveland Clinic. So I'm really, really pleased for you. And thank you to the audience for dialing in and listening. So we're told there's 41 of you. But thank you very much indeed.
Great. Thank you, Robin. I really appreciate it. It's been a pleasure talking to you. Thank you very much. Good night, everybody. Thank you.
Bye-bye.